share your screen.
Sure. Is it okay?
Yes, sir. The screen is visible. Yes, sir. So
Okay.
we'll start in a minute.
Yeah. Okay.
Thank you. Praveen sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's special National Distance Learning Seminar session. Today's topic is clinical case presentations from SACEP among children, and the speaker is Dr. Sanjeeva sir. Dr. Sanjeeva sir is currently working as Associate Professor of Pediatric and Program Director for Pediatric Center of Excellence in HIV Care and the in charge of the Genetic Clinic at the Indira Gandhi Institute of Child Health, Bangalore. He serves as a special invitee for Pediatric TRG NACO and as a resource person for the trainings on pediatric HIV. He has published several papers in various national and international journals and has represented it in various state, national, and international platforms. We welcome you, sir, for today's session and request you to start the session.
Good afternoon. Thanks for that kind introduction. Today, we are discussing more or less on treatment failure in children and a case-based approach, how to approach children, treatment failure and second-line initiation through the various cases what we see in our SACEP meetings. So basically, just a minute. Yeah. Yeah, there are some challenges in children when it comes to the virological suppression, because in children their baseline viral load is unusually high as compared to the adult. There are various factors which are responsible for this situation. Similarly, most of the children are acquiring their infection either in the intrauterine life or during the perinatal period of their life. And when this infection happens, their immune system is immature or it's still developing. Whereas in adult, it's already a mature and developed immune system. And the HIV infection happens in that scenario. Whereas in children, the immune system is still developing and still immature. That's why it will take longer time for the viral suppression. Similarly, children are dependent on other caregivers for their adherence support. They can't take care of themselves. They are young, they are small, they don't know the consequences of poor adherence and other things. And another important aspect of pediatric HIV is the dynamic dosing, especially with respect to weight. As we know, when we start a child on an antiretroviral therapy, child will start gaining weight and child dosage requirement will go up. Sometimes child may lose weight, your dosage requirement will come down. So you have to be always constantly watching their weight and adjusting their dose. Otherwise, it will become an underdosing or an overdosing. So the dosing is dynamic in nature. So you have, that's also one of the reason many times we may forget to hike up the dose or decrease the dose. So we may end up with non-suppression of viruses. Similarly, the child-friendly formulations are not available. So we may be forced to modify the adult tablets many a times and give it. Those are again will result in suboptimal therapeutic responses. So these are some of the reasons why the virological suppression is not very optimal in children. Now, in spite of good adherence, we all know that we in the field of HIV, we all know the importance of adherence. So a good adherence is equal to long-term virological suppression, and that's a prevention against the treatment failure. Whereas in children, in spite of good adherence, we do see treatment failures, because these children who are on long duration of ART, despite optimal adherence, may also develop treatment failure. This is as a result of accumulation of drug-resistant mutations because of unusually high replication rate, as I described in my previous slides. And these children, the virus is also very error-prone, especially with respect to the reverse transcriptase because of high replication rate. And naturally, due to selective pressures from the drug or from the immune system. And also we should understand that these children has got a very long life ahead, and they are going to live for a longer time, and their requirement of ART is longer duration when compared to the adult. So all these things emphasizes on a point that the viral suppression is not very optimal, and even in spite of your poor adherence, good adherence, the treatment failure can happen. So the important point to note is the pharmacological options for second-line ART in children are very limited, because the pediatric formulations are not available easily, and there is also a prenatal exposure to the antiretroviral drugs. So all these factors emphasizes a point that it is very important to support and promote the factors which facilitates and sustain the response to the first-line ART regimen as long as possible. If you don't do that, because of a limited pharmacological option, we'll end up with nothing, or we end up with a suboptimal regimen for these children. That's the reason why this whole session has been planned. How the different cases and how we approach, and what are the bottleneck and what are the problems in pediatric HIV when it comes to second line ART and the formulation of second line ART. We all know how to define a treatment failure in children. What is important for is the first virological failure. Without virological failure, we don't label a child as a treatment failure. And how do you define virological failure? 2 consecutive HIV-1 plasma viral load values of more than 1000 copies ml with the following criteria. The first criteria is after 6 months of ART initiation, and after giving 3 sessions of step-up adherence counseling, and adherence in each of the last 3 months was more than 95%. So with fulfilling all these criteria, if viral load is more than 1000 copies in 2 consecutive HIV-1 plasma viral load, then we we can label the child as virological failure. We also have immunological criteria and clinical criteria, but these 2 criteria, even if the child is fulfilling that, we have to confirm this with a virological criteria. Now, the first case, it's a very simple case. Here, there is a child, Master B, was infected with HIV, and he is aged around 14 years, presented with oral candidiasis, severe wasting and stenting. His CD4 was 3 cells, and TB screening was negative. So his first line was started, zidovudine, lamivudine, and efavirenz. This was long back when dolutegravir was not even available at that time. So 4 months later, he presented with a behavioral change, it is agitation, for 2 to 3 months, and severe headache and vomiting for last 2 to 3 days. Now here this child has presented with a new onset symptom. The possible things may be new opportunistic infection, or it may be a drug reaction, or it may be iris, or it may be a treatment failure. So when this child was evaluated, MRI showed multiple tuberculoma in the brain, Repeat CD4 count shows 100 cells per mm cube. And a new event developed within 4 months of starting ART, and also there is a partial immune recovery. So a diagnosis of TB iris was made, new onset iris was made, anti-tubercular treatment was started along with steroid because this is CNS tuberculosis. ART was continued and adherence to therapy was emphasized. So here the treatment failure is not considered, because you remember the first slide in the previous slide where I mentioned the criteria for virological failure is viral load more than 1000 in a child who has received treatment for at least 6 months. Here the duration of first line ART was less than 6 months. That's why the treatment failure was not considered. This case emphasizes that even though apparently it may look like a treatment failure, you need to consider other conditions like iris, opportunistic infection, adverse drug event before you label a child as treatment failure. Now, when to suspect treatment failure in CLHIV? A child should have received at least 6 months of first line ART. Adherence to the therapy should be optimal, that is more than 95%, at least in the 3 consecutive previous months. Treat and resolve any active opportunistic infection before interpreting CD4 counts and other things. Iris must be excluded. Primary malnutrition should be ruled out because primary malnutrition can mimic treatment failure. Adverse drug events manifesting like treatment failure should be ruled out. All suspected clinical and immunological treatment failure should be confirmed by virological criteria for treatment failure. And you should always, you can use the expertise available at the Pediatric Center of Excellence or COE or ART Plus if you have a doubt to clarify on the treatment failure and the further management of these children. The second case, here a 14-year-old boy presented with a declining CD4 count. He was started initially on SLN, and then 3 years back, it was changed to zidovudine, lamivudine, and efavirenz because of the SLN was phased out. Adherence was less than 95% in between. So we have a 14-year-old boy presented with declining CD4 count, substituted to zidovudine based regimen 3 years back. His plasma viral loads in 2 consecutive was around 132,000 and 28,000. This was after step-up counseling. Now, what is your option? Will you switch over to second-line ART or you do something else here? If yes, what regimen you are going to switch over? The weight of the child is 10 kgs and hemoglobin is 10 gram per deciliter. So definitely this child is having treatment failure. This child is on therapy for quite more than 6 months of life. He has got declining CD4 count. So the immunological failure, which is confirmed by virological failure by viral load assessment on 2 consecutive times, in spite of step-up counseling, adherence counseling, his viral load is still above 1000. So this child is having treatment failure. The appropriate plan of management is switch over to the second line ART. So the appropriate ART regimen was tenofovir, lamivudine, and dolutegravir, because tenofovir can be used for children about 10 years and body weight of more than 10 kgs. Both the criteria is fulfilled in this child. So his second line ART regimen will be tenofovir, lamivudine, and dolutegravir. So now this is viral load and the algorithm, where when you do a viral load, if the viral load count is more than 1000 copies per ml, a counselor should provide step-up adherence package to the patient for 3 months. If the adherence in the last 3 months is more than 95%, then, or if the viral load is less than 1000 copies, we can continue on same treatment. If in spite of step-up counseling and adherence is more than 95%, you have to conduct another viral load. If that viral load copy is more than 1000, then this child should be referred for second line ART regimen evaluation. Now, the third case here, a 9-year-old girl diagnosed and treated for pulmonary tuberculosis. This was long back when we were using category 1 anti-TB treatment. After 2 weeks of ATT, she was initiated on first line ART, that is abacavir, lamivudine, and efavirenz. Her adherence was poor with intermittent miss and LFUs for several months. 2 years later, she presented with history of cough, fever, loss of weight, and appetite for 6 months. So after the examination and investigation, she was found to have recurrent TB and evaluated for MDR TB, and appropriate ATT was initiated. So her CD4 count, you can see initially there was a good response, and then it was started declining. When there was a pulmonary TB recurrence with a poor adherence, it further declined. The corresponding viral load was also high. So as recurrent TB and reduced treatment adherence could be contributing factors for CD4 drop and high viral load. So the plan of action is treat the TB recurrence with MDR TB evaluation, step up adherence counseling, ensure 100% adherence by enhanced and repeated counseling. You need to see one thing here. This child has failed very early in the treatment, for the first line ART regimen. Almost within 2 years, this child showed the treatment failure signs. So the very important, and probably this is because of poor adherence. So it is very important to ensure the 100% adherence by repeated and enhanced counseling, step-up counseling for this patient. Monitor the child. Repeat viral load after 3 months. When it was around 27,000, which was around 1 lakh something, it came down to 27,000, but still it was high. So again, this child should be switched to the second line ART. Another case where a 10-year-old child boy referred to SACEP with a history of for the virological failure. So the history goes like this. This child was started on ZLE based ART regimen 7 years back. After initial good adherence, the child was lost to follow for an year because of social reasons, some parental death and caregiver change and other things. When he re-entered into the ART service after the last to follow-up, before last to follow-up, he was doing fine. And with the last to follow-up, he came with severe respiratory infection, probably PCP pneumonia. CD4 count was dropped to 77, which was 5%. Viral load was 8 lakh and odd. So this child's step-up counseling was done. Treated, acute OI was treated. He was restarted on the same regimen, that is ZLE. So after 3 months of adherence counseling and adherence improved, his viral load dropped, but still it was high. CD4 improved, still it was low. Hence the child was referred to SACEP for the evaluation. This child, in spite of good adherence and in the last 3 months, still having viral load high, this child was considered as a treatment failure, and the panel recommended to switch to the abacavir, lamivudine, and dolutegravir because his weight was 24 kgs, and though his age was 10 years and above, but his weight was still less than 30 kgs. So abacavir was advised, and step-up adherence counseling was done. And after the switch to the ALD, a repeat viral load done at 6 months showed a good viral suppression to 947, and CD4 count, there was an increase in CD4 count to 256. So second line ART regimen, when the child, if the first regimen was ZLE and the age between age is more than 10 years, but still weight is between 20 to 30 kgs, then the regimen of choice is abacavir, lamivudine, and dolutegravir. If the weight is more than 30 kg, we would have started this child on tenofovir based regimen as a second line regimen. Now, this child, a 3-year-old child, was referred for review for the treatment failure. This child was nevirapine exposed and then initiated on zidovudine, lamivudine, and ritonavir boosted lopinavir at the age of 6 months. I think this is a common story we are going to see in most of our ART centers. So currently, this child is 3 years, weighing around 12 kgs, clinically asymptomatic. But the viral load, when it was done, it was around 2,600 and 27,000. Corresponding CD4 count was 989 and 446. Now, here there are multiple problems here. This child is exposed to both NNRTA as well as protease inhibitor. Otherwise, child doing fine with respect to clinical features as well as nutrition wise. But viral load is high. CD4 count is more or less okay, but still there are some issues with the CD4 count. Now, in the SACEP, this was the recommendation. As the child was less than 6 years of age and weighing less than 20 kgs, the second line ART options are very limited, not available in the program. So the current guideline says in the age is less than 6 years and weight less than 20 kgs, zidovudine, lamivudine and lopinavir was the first line regimen. So if the child is asymptomatic, then probably you can continue with the same regimen, the close monitoring. Close clinical, nutritional, immunological, virological monitoring with a good optimal adherence till such time when child reaches 6 years of age and weighing more than 20 kgs, when we can use the dolutegravir. If that is not possible, then with the consultation with PCOE, we can try the ALN or abacavir, lamivudine and efavirenz. Suppose if you use instead of zidovudine abacavir, now it will become monotherapy and you are going to lose the abacavir also. So you have to be very careful when we are planning a second line regimen in these type of children. So these are real challenges. The treatment plan should be decided based on case to case basis. Now, this 5-year-old child was referred for treatment failure. This child was initially started on zidovudine, lamivudine and nevirapine, and regimen was substituted to ALE because child developed anemia. At that time, the CD4 count was 272 and 18%. This child was referred to SACEP in 2 years later with viral load of 1744 and 1356 with CD4 count of 388 and 326 respectively. Reported adherence was 100%. No major OIs were documented or reported. So SACEP recommended that this child is exposed to multiple NRTI. This child was initially zidovudine, then abacavir. Hence, the options for second lines are limited. So hence, since the viral load was not very high, it is advised to consider step-up adherence counseling and treat the intercurrent OIs if any. Though the reported adherence was 100%, when it was closely observed, there was some issues in the adherence. So a repeat step-up adherence counseling was advised in this child. This child needs to be closely monitored clinically and lab parameter during this period. When the viral load was repeated after 3 months after step-up counseling, the viral load was less than 20 copies. That is TND. So it is complete suppression. So when the first line treatment failure with history of multiple NRTI exposure, sometimes you have to use the strategy of not changing the regimen if the child is clinically stable. If child is clinically not stable, there is a progression, then probably this child needs a PCOE, RSCOE or a ART plus pediatric expert consultation. Because the options what we have is almost like a third line option, that is DTG and LPVR, which moves to the effectively third line. So we have to be very careful when we are moving a child to third line regimen, because the future options are very limited in these children. So general guidelines for step-up adherence is a minimum of 3 sessions are recommended. All counseling sessions are to be taken preferably by the same counselor, because the rapport which is built, the continuity of the counseling and the content of counseling, there will be a status quo maintenance. Both caregiver and child should be counseled together and individually in all the sessions. Counselor needs to review all the barriers that led to the poor adherence and provide customized counseling. A customized adherence plan should be developed with involvement of both caregivers and the child, and assessment of mental health of the caregiver and the child and timely referral for appropriate management is very important. Nowadays, we are seeing a lot of children and even caregivers with depression and other mental health illnesses, which come in the way of maintaining the good adherence. A 15-year-old girl was referred for review. This child was initially started on zidovudine, lamivudine and nevirapine with a baseline CD4 count of 4%. 1 year later, when child developed zidovudine related anemia and CD4 count was 98 and 12%, this girl was substituted with abacavir. substituted to abacavir from the zidovudine. Adherence was less than 80%. 3 years post ERT initiation developed tuberculosis. So the regimen was modified to abacavir, lamivudine, and efavirenz. The viral load was 9 lakh plus and 10 lakh plus after 2.5 to 3 years of post ERT initiation, post tuberculosis. So CD4 count were 42 and 9%, 9, that is 1% respectively. Though she is around 15 years, her weight was 22 kgs. So the recommendation was switching the regimen. The challenge, the problem here is this girl has already exposed to zidovudine and abacavir. Her weight is 22 kg, so we don't have a tenofovir option. And the another problem is tenofovir is when the child is exposed to abacavir, there may be a chance of common mutation which can lead to cross-resistant to tenofovir. And pediatric formulations are not available for children less than 30 kgs. Tenofovir is not available. Though recently there was some discussion and where it was advised from the national AIDS clinical expert panel that adult drug can be modified and given, though there are some concerns on that. So here the switching the regimen definitely is required, but the appropriate regimen in this condition was since when the zidovudine was taken out from this child, so there was some clinical response when the zidovudine induced anemia was there. There was a clinical response, that is CD4 count was improved from 4% to 12% and 35 to 98. So it was decided to re-challenge with zidovudine. So zidovudine, lamivudine, and DTG with a close monitoring of HB. This is what the guidelines also says. Re-challenge zidovudine if current hemoglobin was more than 9 gram. So here it was 10 grams, so that was re-challenge. Follow-up viral load was done, which was still high, but it was down. But the child came back with history of pain abdomen, loose stools, and hepatosplenomegaly when it was seen. So child had bone marrow suppression. So this child was taken, the zidovudine was taken back and started on lopinavir and dolutegravir in the BD dose, along with abacavir and 3TC as a recycled regimen. So the next case is a 6-year-old child with suspected second-line failure. This child was initially started on abacavir, lamivudine, and lopinavir based regimen at the age of 5 months. So this regimen was switched at the age of 4 years because of virological failure to zidovudine, lamivudine, and efavirenz. 1 year later, that is at around 5 months, child was again referred for persistent unsuppressed viral load. So here the viral load was 4,000 and 4,500. CD4 count was good. Child was weighing 17 kgs. Clinically, child was asymptomatic. This child was around 5 years of age, 5 to 6 years of age. Since this child has failed on all available ERT regimen, this child was, zidovudine was used, abacavir was used, protease inhibitors were used, efavirenz were also used. So NSAP, the case was referred to NSAP. So NSAP recommended that to continue the current ART regimen, that is ZLE, and ensure good adherence. When child reaches body weight of 20 kg, the regimen can be switched to DTG based regimen. So this is the recommendation. Less than 6 years and less than 20 kgs. So continue the second line regimen with emphasis on the adherence to ART. Better to continue PI based regimen, but here the child is already failed on that. And once the child becomes 20 kgs, then dolutegravir, maybe a different PI may be used, or if available, we can do the resistant testing and see what are the drugs available for this child. So here a 10-year-old child was referred to SACEP for the suspected first-line failure. Child was initiated on abacavir, lamivudine, and efavirenz 4 years back. In December 2021, this child was referred with a high viral load, also diagnosed with extrapulmonary TB. Viral load was 66,000 and 85,000. CD4 count was 373 and weight was 17 kgs for a 10-year-old. Referred to SACEP for review. So this child was switched to zidovudine and lopinavir based regimen because still weight is 17 kgs. So retinavir super boosting was advised, and this super boosting should be continued for 15 days after completion of anti-tubercular treatment. So any child who is on where a ART modification is required because of rifampicin based ATT regimen, if the child is on retinavir, lopinavir based regimen, protease based regimen, then super boosting of lopinavir with the retinavir in the ratio of 1:1 is advised. If in a DTG based regimen, then the BD dose is advised. Efavirenz, no modification. If the child is on DTG and LPVR, then double the dose of DTG and super boosting of lopinavir with retinavir is advised. All these super boosting or modification is advised to continue for 15 days, for 2 weeks after completion of anti-tubercular treatment. So when the child being identified with the first line ART failure, presenting with the tuberculosis simultaneously, ATT should be initiated. It's a priority. Second line ART regimen should be started as soon as possible within 2 weeks of initiation of ATT. A 12-year-old boy was initiated on zidovudine, lamivudine, and nevirapine ART 8 years back. So a 12-year-old boy was initiated on zidovudine, lamivudine, and nevirapine 8 years back. So 3 years later, he developed zidovudine-induced bone marrow suppression. Hence, his regimen was substituted to abacavir, lamivudine, and efavirenz. So look at this. His CD4 count was 1065, 28%. Remember, when these cases were recorded, the routine viral load monitoring was not available. But now routine viral loads are available. We can even document the viral load during that time. So now this child, after 8 years of ART, he has presented to us with immunological and virological failure. His recent CD4 count is 78 and viral load is 59,66,000 and odd. So now this child, what are the options we have? He's a 12-year-old. We can definitely go for zidovudine, but his weight is less. So he was switched to zidovudine, lamivudine, and lopinavir based regimen. Because when the bone marrow was suppressed, zidovudine induced bone marrow suppression was seen, he was not in failure. So that's why it was decided to re-challenge with the zidovudine. 3 months after the regimen was switched, this child developed decreased vision in the left eye. On examination, child had no perception of light in the left eye. Pupil was mid-dilated and non-reactive to light in the left eye. And in the right eye, finger counting at 6 feet was seen. Ophthalmologist opinion was taken, and it showed that granulomatous inflammation with extensive hemorrhage and vasculitis in the both eye. So in the view of extensive hemorrhagic component, which is not classical of CMV retinitis, other things were considered. TB workup and VDRL was done. Everything was negative. Even your sarcoidosis was also ruled out. Hence, CMV retinitis was considered. So this child received intravitreal ganciclovir in both eyes under GA, along with IV ganciclovir for 14 days with close monitoring. Prednisolone eye drops was started. So this child was then started on oral ganciclovir for 4 weeks. This is a classical case of CMV iris after starting of an effective ART. So ART was stopped in order to prevent the visual loss. So we can say fortunately and unfortunately both. Unfortunately, because we could not able to revive the eyesight on the left side, but somehow there was some clinical improvement of vision in the right eye. We could able to preserve vision in at least one eye. So the important is we have to consider IRIS even in the second line ART regimen, ART initiation also. IRIS is something which can happen even with the second line ART regimen. Always keep that in the back of your mind when you are changing a drug for a child. When the CD4 is very low and viral loads are very high. With this, I'm concluding my today's presentation. So early and correct identification of treatment failure is very important in children for appropriately selecting the second line ART regimen. In children, ARV options are limited and poor adherence plays a significant role in the emergence of drug-resistant and subsequent treatment failure. Regular viral load testing in children helps in the early identification of treatment failure. Second line ART is being provided for all eligible children after approval of SACEP. Now even, it's available at all the ART centers. Only thing is e-approval is required. 100% treatment adherence is vital for the optimal efficacy of second line ART. Repeated and continued counseling is necessary for children and the caregivers. And you should, in all cases, it is highlighted that how complex and difficult is the whole scenario of pediatric second line HIV, because the limited options, multiple exposures. So to curate an appropriate regimen is a really challenging situation. Thank you. Any questions? I would be happy to answer.
Thank you so much, sir. Sorry, we couldn't take this presentation in a discussion mode because it would be too time consuming given the number of case studies that have been put in. Any questions from the participants? You can either unmute your mic or you can put your question in the chat box. So we have one question in the chat box: how to monitor for bone marrow failure after re-challenging with AZT?
Yeah, simple is you can do CBC. I mean, just like when you start a Zidovudin initially, we do initial day 15 and every month, then onwards up to 6 months. So you keep on doing CBC. CBC will definitely give us idea where hemoglobin and platelet count and even total count may be low if there is a complete bone marrow failure. Initially, it will start as anemia and slowly there may be other component may be involved. And that's a simple thing we can do. If available, we can also do LDH and you can also monitor your MCV. So, but simple complete blood count is good enough to monitor bone marrow failure, bone marrow suppression in any scenario, even in re-challenging of AZT or even routine AZT also.
Thank you, sir. Any more questions from the participants? Please feel free to unmute your mic. So there's one more question. In case of 4.1, so is it possible to go back to the slide, sir?
Yeah.
4.1. Right. How would you restart the ART regimen after LFU if efavirenz is phased out?
No, this is a real scenario what we had seen in our PSAP. If now the currently efavirenz is phased out, we don't have that option. So then whatever the options we have now, dolutegravir is there. If this child is eligible for dolutegravir, probably we'll have to go to the dolutegravir. Maybe we need to consider switching directly into the second line regimen. Suppose, the point here is, suppose if the child was previously on abacavir, lamivudine and dolutegravir and then LFU and then came back later. The point here is we have an option of restarting the same regimen there. So wherever it is available, better to restart the same regimen before you label the child as treatment failure and completely switching to the next regimen. So this was a real scenario when the efavirenz was available. This was done, and this is the lessons what we have learned. This is the lesson what we want you to learn from this case. That's all. If it is not available, then whatever is available, we are going to use that.
Participants are requested to put their questions in the chat box. They can also unmute their mic. So I don't think there are any questions.
Okay, then.
Thank
you.
you so much, sir, for facilitating this session and putting so many case studies and so much of exposure to everyone. So can we quickly run the feedback form now? Praveen, sir, can we have the feedback form, please?
Shall I stop sharing
Yes,
the
yes, sir, you
slides?
can do that. Yes, sir. Just give
Okay.
us last 2 minutes just for the feedback, sir. Participants are requested to please fill in the feedback poll. Sorry, that's a NDLS session, not a RDLS. Sorry for the typo error. Requesting all the participants to take up all the 4 questions. Thank you to all the participants for patient listening. Praveen sir, we can end the feedback poll now. Thank you, everyone. We'll conclude the session.